Okay, so we're going to talk about the corticosteroids and respiratory care. We've mentioned the steroids when we talked about the beta agonist. Remember, your LABAs have to be mixed with corticosteroids. So we have a lot of those that have, there's three major ones, but we have a lot of the corticosteroids we're going to take a look at along with some of the major ones of those. So we're going to look at some of the terms that pertain to corticosteroids. Why do we use them? How are other ways that we can administer them? We have the inhaled ones, we have the SVNs, we also have the tablets. And the tablets are what really get us in the liquid form, I should throw that into this too, are the ones that give us the most systemic reaction. We see this with patients not only who have respiratory problems, but some with rheumatoid arthritis and other conditions where they need them. And we see a lot of the systemic problems with those. We're going to take a little look at the white blood cell count. One of the things you have to keep in mind when a person is on corticosteroids, especially those that they're receiving by IV or systemically, they look like diabetics. You're going to see folks tell you, I don't have diabetes. I don't know why they're doing the finger sticks. I don't know why they're doing this. Well, as long as you're on them, it looks like you're a diabetic. And they will classify you as that until there's some way to convince them that you're not, okay? The nice thing about the corticosteroids, and we're going to see this, is that basically they help the beta agonists do their job better, and the beta agonists help the corticosteroids do their job better at that particular point. So clinical indications, orally, this is your lung delivery, intranasally, is another one. We're coming to that time of the year where people are starting to use the inhalers in their noses to be able to take care of their seasonal allergies. One of the things that I heard one time talking to some doctors was basically before you use your inhaled corticosteroid, go ahead and put some normal saline, squirt your nose with a little bit of normal saline, and then you can use your inhaled corticosteroid, and it seems to help a little bit. Other ways that we can use them are maintenance or control of chronic asthma. You can see there's specific guidelines in our NAEPP, which is your program for people who have asthma, and they tell you when do we start with the inhaled corticosteroids. At one time, we didn't start quite as early as we do now. We found out, and we probably knew this, but it was just one of those things that you didn't really think that much about, is that asthma is an inflammatory disease problem, and corticosteroids are probably some of the best anti-inflammatories that you have, okay? You can also see that when we mix them with our inhaled agents, we use those for severe asthma. And sometimes, if patients are on pills or liquids or something like that, if we start them on the inhaled corticosteroids, we can sometimes wean them off of the systemic steroids at that particular point. So these are some of the aerosolized corticosteroids that we have. Beclomethasone or Qvar is one that's more of a home care drug, and a lot of your patients will tell you that they like their Qvar and they want it more than anything else. Fluticasone or Flovent, we've used that for quite a while. We mix it with Ceravent to get Advair. Been on the market for quite a while, okay? It also comes as its own inhaler, comes as a discus, all of those good things. Bumosicide is Pulmicort. It's a Flexihaler. We mix it with Floridil, and when we mix it with Floridil, we get Symbicort, okay? Then Mometasone, this Asmanhex or Asthmatix, just depending on how you pronounce it. We mix it with Fluticasone also, and as a result of that, then we get Dulora. So there you can see the mixtures at that particular point, the different things we mixed together. Breo is a new one on the market that came on a couple of years ago. When Breo first came out, what it basically said was there's no use for it in asthma. We weren't sure what the long-term effects would be. And then in the last year or so, if you watch any of the TV commercials, you'll see that Breo has been added to the asthmatic regimen. And one of the things it'll tell you is that basically once you're pretty well maintained, the doc needs to take you off. They can leave you on the inhaled corticosteroid, but take you off the other portion of it. And then there's the Trilogy Elliptica. This is your triple drug mixture for COPD, your LABA, your LAMA, and then your inhaled corticosteroid. So remember that the adrenal cortex is what secretes your corticosteroids. You have three different types that are produced by the adrenal corticosteroids, the glucocorticoids. These are R's, along with cortisol and hydrocortisone. These have an anti-inflammatory effect on the body. Then you have the mineralocorticoids. These regulate body water. This is your aldosterone, increases the sodium reabsorption in the renal tubules. And then you have your androgens and estrogens, and those are your sex hormones. So this is something that I'm sure you guys talked about in So some of the effects we see with the corticosteroids, they regulate metabolism of macronutrients. They alter the way these nutrients are metabolized. And this is your carbs, protein, and lipids. They increase the glucose level for the body energy. They can cause liposis, redistribution of fat stores, and the breakdown of tissue protein stores. You're going to find when you deal with patients who are inhaled corticosteroids, or the tablets or the liquid, whatever they are, lots of side effects. And as a result of these side effects, if these people really haven't convinced themselves that they need these steroids to live with, sometimes they're not going to adhere to the regimen that's been outlined for them. Other problems that we see with these include our sore throat, candidas, hoarseness. Sometimes I remember we talked to a physician, and the physician said if he's giving inhaled corticosteroids and someone develops hoarseness, then unless there's really a good reason for stopping them, he'll continue to let them do that, and they have to learn to live with their hoarseness at that particular point in time. One of the things that you as a therapist need to do when you're educating your patients is if they're using inhaled corticosteroids, they have to rinse their mouth out. They have to brush their teeth. Otherwise, what's going to happen is they're going to end up with a lot of problems at that particular point. The other thing, trying to limit some of these side effects, we can also use a spacer so that can help them as far as that goes. And this is just showing you some of them really, really quickly. And, sometimes the body's not quite sure what's going on, at this particular point. So when we give our corticosteroids, then we have our increase of hormones in the body. They inhibit the hypothalamus and pituitary glands, and this will cause problems. As you can see, they're seen with systemic administration after 1 day of treatment and significant after 1 week of oral therapy. If you've ever known somebody who's started on oral steroids, after a couple of days, they're probably not some of the nicest people that you ever ran into. Very low tolerance and things. We're going to talk about some of the problems that we see with these. So steroids work with the diurnal steroid cycle. This is something that you get with the body, and it has to do with things like light exposure, the physiological dimensions of effect, immune function, systemic health, different things along that line in your well-being. It's not a simple response to alternating day and night. It arises from an innate and genetically operated timekeeping system within the body, and it's referred to as your biological clock. The internal timekeeping system allows organisms to anticipate and prepare for changes in their physical environment, and enabling them to behave appropriately at the right time of day. And so when we're giving you steroids, we have to be able to follow these cycles, okay? As you can see, daytime work, nighttime sleep, your cortisol levels are highest in the morning at 8 a.m. What interferes with this? Jet lag, night shift work. People think it's very easy to go from a day shift to an evening shift to a night shift every 2 weeks or so. It's not. You really mess up this biological time clock, and it causes lots and lots of problems for these folks. So some of the things that we can do are alternate day steroid therapy, because what happens if we're giving you the oral steroids, the systemic steroids, is that we're going to go ahead and suppress your adrenal glands. And so basically what we're trying to do, as you can see here, mimic the natural diurnal rhythm, giving your steroid drugs early in the morning when your tissue levels are high. This is where we want them. Every other day, we go ahead and we skip a day, okay? And what this does is it minimizes the tissue side effects, and it allows then for the alternate day dosing at that point to where you still have the adrenal glands working and doing the things that they need to do. So the major therapeutic effect of natural hydrocortisone is anti-inflammatory. The glucocorticoids that we use for treating asthma take care of the inflammatory process in the lungs at this particular point. And this is your nature of the inflammatory response. Just something very interesting to look at, the things that we would actually see as far as that goes. The other thing we see, phagocytosis. Remember, you have the white blood cells, the monocytes, the macrophages when they start moving. These are the guys who ingest and process all your foreign material in bacteria. Then you have the mediator cascade. This is your histamine, along with other neutrophils and other inflammatory mediators that show up when we're having problems at this particular point. So, nature of the inflammatory response, inflammation of the airway, you have chronic bronchitis, normally caused by tobacco smoking. Asthma has a wide range, intrinsic, extrinsic. You're going to talk about a lot of that when it comes to diseases. There you can see also with asthma, it's a disease with chronic inflammation of the airway wall, and you do end up with airflow limitation and hyperresponsiveness to various stimuli. So we treat you with these corticosteroids that help to reduce the airway inflammation, allowing you to breathe better at this particular point. It also helps reduce the hyperairway hyperresponsiveness and predisposition to acute episodes of obstruction. So when we see here, and this is kind of interesting that goes with it, the asthmatic reactions are biphasic. You have an early phase and then a late phase. The early phase is caused by the IgE, the immunoglobulin E, which activates the mast cell, and this peaks about 15 minutes. What happens with the mast cell, it has a lot of the inflammatory mediators on it. It has histamine, it has heparin, it has prostaglandin, all of these other ones. And the leukotrienes are sitting out there away from it. And when the mast cell degranulates, it sends it out to the leukotrienes, and then they go ahead and they start the reaction too at this particular point. The mediators release the cytokines, and the cytokines also come out. And what they do is they recruit more inflammatory mediators. And so then we'll see a response after 6 to 8 hours, and sometimes these responses can last up to 24 hours. So the use of our corticosteroids targets inflammation in the airway. It reduces the systemic side effects. This is what we want to do, reduce these systemic side effects. And as I told you, when we use the beta-adrenergics and the glucocorticoids, they work with each other. They improve the reaction of both of these medications, makes it much, much better for the patient at that particular point. Your intranasal corticosteroids, you can use those in the nasal passages. Remember, sometimes you can pre-rinse with the normal saline, makes it much easier for you. Talk to your physician if you're using these, because sometimes what your physicians will tell you is that you need to go ahead and use these steroids for about 3 weeks. But it takes about a week and a half, 2 weeks for them to onset, and then you need to stop because you're really causing a lot of inflammation, even though this is an anti-inflammatory. Your glucocorticoids are lipid soluble, which is really good because remember, you're phospholipids, so your cell membranes, so it can cross over those. They act on intracellular receptors, and that's where you get this anti-inflammatory effect. So it's inducing the gene expression for anti-inflammatory proteins and receptors, and then it suppresses these expressions that we have. So here you can see there's an upregulate transcription of anti-inflammatory genes. You can suppress factors such as activator protein 1, which cause transcription of the genes involved in inflammation, and then you upregulate the expression of inhibitors of your natural function at that particular point. So what happens on the white blood cell? Deplete the neutrophil stores at that particular point. Neutrophils are part of the inflammatory process. Neutrophils are going to send out the message that says we need help, and that's part of the inflammatory process. There's an overall increase in the white cell count, especially the eosinophils, because our eosinophils are telling us that there's asthma going on at that particular point. And then there's constriction of the microvascular that reduces the leakage of the cells and fluids into the inflammatory sites. The effects on your beta receptors, it restores the responsiveness to them, and it makes it work better for us. And that's one thing you have to just keep in mind, that it improves the response of the beta agonist. So there you can see with these, we restore the beta-2 agonist responsiveness within 4 hours after you give the IV administration of your steroids. Basically, the rationale for administering a bolus of steroids and status asthmaticus is part of an acute treatment. We know it's not going to happen right away, but we do know that it's going to come along and it's going to start helping us, okay? Status asthmaticus is the point where your patient can no longer breathe. They have a lot of really tight, faint wheezes that are going on, and most of these times these guys are going to have to be intubated in order to survive. They enhance the beta receptor stimulation, okay? They increase the affinity for the receptors for the beta agonist, and they prolong the endogenous circulatory catecholamine action by inhibiting the uptake 2 mechanism. It's gonna help you with it, okay? Now, one of the things, if you're not in status and we're going to prescribe steroids to you, we're going to give you the tablets. Remember, we can do alternate day dosing. Alternate day dosing helps protect the adrenal glands. You need to remember that when you're using these tablets, it takes about 3 days for us to see the effects of them. Once you're finished with those tablets, then you're going to still have that reaction once the tablets have been stopped. So you're going to see both front, a little bit longer in the front, but a little bit longer at the end also. So there it is, suppression of your HPA axis, immunosuppression. Big ones, steroids are opportunistic infections, okay? They are going to get wherever they can go and cause an infection. This is one of the major reasons that we tell our patients you have to rinse your mouth out. Otherwise, you're going to end up with thrush or candidus. At that particular point, you also have to protect your teeth. You need to brush your teeth after you do this also. There's psychiatric reactions. It uncovers some people who have psychiatric conditions, shall we say. It can form cataracts. It causes myopathy of striated skeletal muscle. It causes peptic ulcers. Steroids, systemic-wise, are harsh on the body, very harsh on the body. We mentioned before they alter your metabolism. They help people put on weight. I mean, it's just very sad sometimes to see these folks because people think, well, these people don't care about themselves. Look at they weigh 200 and some odd pounds. If you look at them, they're not sitting there stuffing their mouth with ice cream, cakes, candy, and things like that. Part of this is happening because they are on the steroids. And we need to remember that because we are therapists and we cannot judge them. We see a lot of fluid retention, and it doesn't take long for this fluid retention to show up. And you can go to them and touch them and see the edema at that particular point. It causes hypertension, increases the white blood cell. It makes changes to the skin. Remember the cushingoid effect, the great big faces, the great big bodies with the very small arms and legs and things that we see with them. Slowing of growth in children. One time we thought it was a major player. Then we came out and said, no, it really doesn't do it at all. And about 6 weeks or 6 months afterwards, they came out and said, well, just to let you know, it does have a slight effect, but it's not a real big one. They weren't going to be 6 feet, and now they're only 5'4", okay? But we do know that there is a slight growth development that's not going to happen, okay? Hyperglycemic, like I told you, these people that are especially good in the IV steroids look like they're diabetic, and they're treated like they're diabetic. And like I said, they're going to stay as diabetic until their physicians decide that they're not. So we also see osteoporosis, a big problem with people, and especially people with asthma who take even the inhaled steroids. We see osteoporosis, osteopenia, okay? And then you can see the different other concerns that we have. So some of the topical or local side effects, there you can see the candidus or thrush, dysphonia. Use minimal dosing. We always try to get our patients to use a holding chamber or spacer to be able to move the particles out so that we can get them down into the lungs much better. Rinse their mouth after use, brush their teeth, protect that enamel. So when do we use them? We use them early in asthma. We bring them on board much quicker. One time when we used to take care of our patients with asthma, if we went up on your steroids, we never went back. Now we know that we can also go back, okay? So we can use them for early in asthma. We can use them for acute severe asthma, something we want to do in the emergency department. And then we can use these inhaled corticosteroids as part of the maintenance, both for people with asthma and COPD. So what are some of the things that we need to do? Need to instruct our patients on how to use these. This is a controller. It's not a rescue agent. Do they know how to use it? Do they know that they have to rinse their mouth? One of the things that we'll talk a little bit more about in therapeutics is the fact that we need to ask these patients, do you rinse your mouth after? And a lot of them will tell you they were never told that, they were never instructed on that, and that's something that we need to do. We need to watch their respiratory rate and pattern, breath sounds, pulse, all of those things. They need to use this peak flow meter in case they have to go up on it. The same thing that we saw with the asthma and the beta 2s, how many exacerbations have you had? How much work or school have you missed? How many times have you been hospitalized? And then let's look at the side effects that we're seeing at this particular point in time. So it's one of the things that we always have to watch.